Welcome to the Neuroblastoma Parent Global Symposium 2021 and Neuroblastoma Australia's Family Conference, which this session is live streaming to. My name is Lucy Jones from Neuroblastoma Australia, and I'll be the moderator for this session. The session is called Current Research Directions, Polyamine Inhibition Project, CBL0137, BCT 100, and New Discoveries. And I'm delighted to welcome Professor Murray Norris. He's the co-head of the Molecular Targets and Cancer Therapeutics Theme and Group Leader of the Molecular Oncology Group, Deputy Director at the Children's Cancer Institute, Australia. If you're watching from the Neuroblastoma Parent Global Symposium, I'd like to draw your attention to the panel on the right of your screen where you can submit your questions. There's the option also to do this anonymously if you choose. When you've posted your questions, they'll be collated and I'll present them to Professor Morris at the end of his presentation. So now over to you, Professor Norris.
Thank you very much, Lucy. And I'd just like to say how delighted I am to be here, to be able to talk about some new treatment approaches that we're developing for high-risk neuroblastoma. So just by way of an overview, I think everybody would probably know that harnessing the patient's immune system to eliminate tumour cells has really revolutionised the treatment of a number of adult cancers, but also paediatric leukemias. Such therapies for pediatric solid cancers, however, including neuroblastoma, are still very much in their infancy. Dinutuximab, a monoclonal antibody that binds the ganglioside GD2, which is an antigen which is highly expressed on neuroblastoma cells, is really now part of the routine therapy for high-risk neuroblastoma patients. So strategies that really are aimed at reactivating the endogenous anti-tumor immune responses, they appear to be highly promising areas of research. So the three treatment approaches that I'm going to talk about today all induce an immune response. And these are polyamine depletion therapy, and this includes using a very old drug, DFMO, plus a new one, Aminex 1501, that I'll talk about. Arginine depletion therapy using a new compound, BCT 100, which degrades arginine. And then non-metabolic pathways, but inhibition of the genetic remodeling complex called FACT, and I'll describe what that is in a little while, and inhibiting that with a compound of curaxin developed by our colleagues called CBL0137. And then finally, I want to end up on the discovery of a brand new drug target in neuroblastoma called RUNX1T1 that we're really very excited about, and just being able to share that excitement with you. So polyamine pathway inhibition. So here we have a picture of a tumor cell showing the polyamine pathway. And polyamines, those three that you see there, putrescine, spermidine, and spermine, make up these polyamines. They're essential chemicals, really, and they're required for critical cell processes, including cell growth. Cancer cells are known to require high levels of polyamines in their cells to support tumor growth. The MYC-N oncogene, I think everyone knows that MYC-N is one of the major players in neuroblastoma. It's quite often frequently amplified. It's a master gene regulator. It drives polyamines to very high levels in neuroblastoma cells. And it also controls ODC1, which is the rate-limiting enzyme in polyamine biosynthesis. And I show that here because the pathway has ornithine, which is an amino acid, which uses ODC1 to be converted into these polyamines. Now, how do we know that ODC1 is very important in neuroblastoma? Well, if you look in primary neuroblastoma, these are neuroblastomas obtained from children, almost 500 of them here. Down the bottom on this axis, we have follow-up time from diagnosis, so when the child was diagnosed, all the way through to 216 months, so a very long time. And on this axis here, we have survival, 100% survival at the top, at the very start, down to 0 down the bottom here. And you can see if you divide these tumours from these children up into those that have low levels of ODC1 versus high levels of ODC1, then those children who have these high levels have a particularly poor outcome. So ADC1 is a very important gene in this pathway, the rate-limiting gene. And as I said, there is a drug, DFMO, difluoromethyl which is a potent and highly specific inhibitor of ODC1. It actually is an irreversible inhibitor, stops it working totally. It's an old drug. It was developed back in the 1970s. Now, if you treat mice in a prophylaxis setting, in other words, treat them with DFMO before there's any tumour formation, so up here on the left, you get a delay in tumour development in these mice, a significant delay. If, on the other hand, you wait for an established tumour to form before treatment, which would be the usual situation in a child, you also see a small but significant delay in the reappearance of the tumour after treatment. However, DFMO as a single agent was tried in the 1980s, and the results in clinical trials were really quite disappointing. And that's largely because of a number of factors which I'll go into, but importantly, because of its role in the neuroblastoma, we looked at combination therapies, and combinations either using DFMO plus standard chemotherapy that's currently used to treat the children, or targeting different aspects of the pathway, which are also important. So here we've taken neuroblastoma-prone mice, the so-called TH-MYC-N mice, and that's taking mice that have the human MYC-N and putting it into the mice as a transgene and only making it active in nerve cells. And these mice get a form of neuroblastoma, which is mirror image of that which occurs in children because it's being driven by this human MYC-N gene. If you treat these mice with DFMO or DFMO plus Celebrex, and Celebrex is a compound, a chemotherapy compound which has a side effect of breaking down polyamines, they by themselves do very little to these mice with tumours. However, and if you treat with cyclophosphamide and topotecan, which is one of the current backbone therapies of neuroblastoma at the moment, you get this quite significant delay before the reappearance of tumours. However, adding Celebrex and DFMO to this backbone therapy, you can see now you're extending the delay in tumour formation quite significantly by many, many weeks. So this and other work that we've done led to an international phase 1 trial of DFMO plus chemotherapy, which was completed in relapsed and refractory neuroblastoma patients. And some of the patients on that study, even though it was a phase 1 study, showed some quite significant responses to this therapy. That's led to now a current phase 2 trial run by the Children's Oncology Group in the USA of irinotecan temozolomide, anti-GD2, the immunotherapy that I spoke about just a minute ago, plus or minus DFMO. So, and that's ongoing at the moment, and so there are no results to present to you. However, one of the things we know about the pathway is, although it's really important in neuroblastoma and you can inhibit it, when you do, the neuroblastoma cells can actually still get access to polyamines by taking it up from the surrounding microenvironment. And these polyamines come from the diet and gut microbiota. So they're there in the microenvironment and they can be readily taken up by the neuroblastoma cells. However, fortunately, there is a compound, AMXT1501, which is a very nice inhibitor of this transport and can completely stop it. And if you do inhibit the polyamine uptake from the microenvironment, this also exerts immune effects by decreasing suppressive immune cells which are present in the surrounding microenvironment. So going back to our TH-MYC-N mice, and if again we look at treating with either Aminex or the combination or the two compounds singly or in combination, you can see now where there's very modest effects when DFMO is given alone. When it's now given with Aminex 1501, this is now resulting in a significant delay in tumour formation. here on that side, and waiting till the tumour forms and then treating. Similarly, now you're seeing that you're getting this quite significant tail and lag. However, what's more impressive than that is if you look at the combination of DFMO and Aminex 1501 in the backbone therapy that I just spoke about, cyclotopo, it's shown in red here, or cyclotopo Celebrex DMFO, shown in green, where you're getting this very nice result. But now when you include it with DFMO and Aminex 1501, these dual inhibitor of polyamines, you're now finding at least 50% of these mice haven't developed tumours by the end of the study. And what's even more impressive, shown in the bottom right-hand panel here, is that when you combine that same therapy with irinotecan temozolomide, which is one of the latest backbone therapies being used, and also include Celebrex and DFMO and Aminex, you can see that 80% of the mice now haven't developed tumour by the end of the study. One of the other things we found, that the dose of DFMO that is being used is very important. Aminex by itself is very effective at stopping any take-up of the polyamines from the environment, and by itself it does very little because the pathway of making polyamines is so active in the cell. But if you add 0.5% DFMO to Aminex, you see a shift and a delay in tumour formation. 1% brings that up even more, but most importantly, the most optimal dosage is a 1.5% DFMO with Aminex. So in summary then, polyamine depletion is best achieved by not only inhibiting the synthesis of the polyamines, but also the uptake from the tumour microenvironment. The combination of Aminex and DFMO is currently in phase 1 trial for adults, and it's been well tolerated to date. The study is ongoing. It's because it's so well tolerated. They haven't reached the dose-limiting toxicity yet. This planning is underway for a joint USA, UK, European and Australian neuroblastoma clinical trial. It's well underway. That will combine DFMO and Aminex plus chemotherapy. So, targeting arginine metabolism. Now, why would we want to do that? Because arginine, of course, is upstream of ornithine. And arginine is an amino acid. It's actually a semi-essential amino acid that's metabolized via this urea cycle into ornithine. And the important thing for neuroblastoma cells is they cannot synthesize their own arginine. They don't have a pathway for synthesizing it. And they are called what is called auxotrophic for arginine. They have to take up arginine from the surrounding microenvironment, similarly to polyamines, except in this case, it's absolutely essential that they do that. And of course, there is a drug, a new drug that's been developed, BCT 100, synthetic drug. It's an arginase, and what does that do? An arginase breaks down arginine. So outside the cell, before arginine has time to get inside of the neuroblastoma cell, it's breaking the arginine down. BCT 100 is currently in a single agent phase 1/2 clinical trial for a whole set of relapse or refractory cancers. So going back to our THMIC mouse model, again, we're seeing in a prophylaxis setting that you can inhibit or delay the tumour formation with giving BCT 100 2 times a week, but more importantly, you get this quite significant delay in tumour formation at 4 times a week. And taking that through into the chemotherapy treatment after tumours are formed in this mouse model, you see our control here where they're developing, relapsing very quickly, that BCT 100 is actually more effective than irinotecan plus temozolomide, but the combination, we've got about 60% of the mice and not developing tumours by the end of the study. We've also looked at taking a number of patient-derived xenografts. So these are cells that have come directly from the patient, going straight into an immunocompromised mouse, and treating with BCT 100 4 times a week significantly delays tumour formation, but the combination with irinotecan and temozolomide, shown in blue, but the combination shown in green, is actually significantly better than either of those two therapies alone. Now, of course, the effect of that is not as great as we've seen in our mice, but this is an immunocompromised model. You cannot grow human cells in a mouse with a fully functioning immune system because they'll just reject those cells. Looking at the plasma samples that were taken from this study, you can see in the red and green here that the BCT 100, either alone or in combination, is almost wiping out arginine in the plasma. And that leads to a significant drop in the level of arginine within the tumour as well, which is what you want to see. So BCT 100 prolonged survival, not only alone, but also when combined with chemotherapy in both our transgenic and PDX models. It reduces the systemic levels of arginine in the plasma and also reduces arginine levels within the tumours. There's this phase 2 study ongoing at the moment of BCT 100 as a single agent in children with relapsed and refractory solid CNS and liquid tumours, including neuroblastoma, is currently underway. And we're working with our collaborators, both here and overseas at the Frank Musa at the University of Birmingham in the UK, to provide the preclinical data for a neuroblastoma clinical trial, which will see BCT 100 in combination with irinotecan, temozolomide, and plus or minus anti-GD2. So the last one of these treatments is targeting FACT in neuroblastoma with the Curaxin CBL0137. So FACT actually stands for facilitates chromatin transcription. Bit of a mouthful, but really all you need to know is that FACT is an essential protein complex that is important in remodeling DNA. So it attaches to the DNA and it regulates cancer-specific genes and also the repair of damaged DNA. But importantly, you see very high levels in cancer cells, but very low levels in normal tissues, which of course means that there's likely to be less side effects using a drug that inhibits this complex. FACT is known to regulate MYC-N levels and also, as I said, to repair damaged DNA. And so high levels of FACT are associated with poor neuroblastoma outcome. Now, there is this compound CBL0137. It's related to the drug quinacrine, which is used to treat malaria patients. And it inhibits FACT. It intercalates with the DNA and traps FACT onto the DNA, but it has potent anti-cancer activity in a range of cancers. So it stops the regulation of these cancer-specific genes and also stops the repair of damaged DNA. And that's important because most of the cytotoxic drugs that are used to treat neuroblastoma patients result in damage to the DNA. And if you stop that damage, then the cell can't repair it and it ultimately dies. So here we looked at looking at 4 chemotherapeutic drugs which are currently used to treat neuroblastoma patients: cyclophosphamide, etoposide, cisplatin, and vincristine. And if you combine each of these with CBL0137, so in each case CBL0137 alone is as good, or in most cases better than the chemotherapeutic agent, but when they're combined together, and that's shown by the dotted lines in each of these graphs here, you can see now that you're getting a quite substantial improvement in survival of these mice, with many of them still being alive at the end of the study. Matter of fact, for cisplatin and vincristine, with the combination, you can see that the majority of these mice haven't succumbed to these tumours. So that was some of the most exciting findings that we've had, but probably the most impactful is when we combine CBL0137 with panobinostat. This is another relatively recent drug that is known to inhibit another remodeling complex of DNA. So similar to CBL, but acting in a different manner, but combined, they're highly synergistic. And that is shown here by this blue line at the top, where 100% of the mice are still alive after treating with CBL0137 plus panabinostat. So a quite remarkable finding. So, however, when we took patient-derived xenograft, this highly aggressive patient-derived xenograft, COG424X, and then treated with CBL, panabinostat, or the combination, you do see that the combination is more effective than either agent alone, but we're not seeing 100% survival now. The mice are eventually all dying. Now, again, this says to us that you need a fully competent immune system in order to see these really strong effects. Now, to explore that a bit further, we actually did an experiment where we took tumor cells from the THMIC-N mice and then subcutaneously engrafted them, so under the skin of the mice, into the flank of the mice, either into immunocompetent mice that have a fully functioning immune system, or into the same immunocompromised mice where the PDX cells are grown, and then treated both these models with CBL and panabinostat when the tumors were at a small size. And we got quite striking results where we got the same result as before, which is the combination, 100% survival of all the mice. However, in the immunocompromised with exactly the same tumor cells, we're seeing only 50% of these mice are actually surviving by the end of treatment. So there is an effect of having a fully functional immune system. And then if you investigate that further, what is that effect? Well, so we looked at the doing global gene expression analysis, and what you see on the left here is a gene expression heat map. And that shows all the genes that are expressed in these tumors, where you've got control tumors here, CBL treated, panabinostat treated, and the combination treatment. And you can see there's a whole bunch there. All these little lines here represent genes. There's a whole bunch of genes, thousands and thousands of genes, which are very lowly expressed in the control cells. But by the time you get to the combination treatment, they've now become really quite highly expressed. And the opposite occurs. All of these genes here, which are quite highly expressed in the control cells, and now by the time you get to the combination treatment, have all been down-regulated. Now, you can use computer analyses then to look at what are the genes and pathways that are affected by all of those genes. The ones that are all upregulated here as a result of the combination treatment, what pathways are they affecting? Well, these are the top 10, and at the very top of these are immune system process, inflammatory process, innate immune response to lipopolysaccharides. So everything to do with the induction of an immune response. If you actually just look at individual genes, there's a lot of interferon regulated genes, and interferon is known to have a major role in the activation of cellular immunity. So you have these interferon genes here, and I won't name them at all, but you can see that in the blue bar, the combination treatment, you're getting strong upregulation of all of these immune genes. Now, interferon, as I said, activates cellular immunity, and so what you would like to see is an increased number of immune cells now being drawn into the tumor, and that's precisely what you see here. Total immune cells, with the combination treatment, you're getting now increased numbers. And if you look at the various subgroups of the so-called CD4 cells and the naive CD4 cells or memory ones, in each case you're seeing greater numbers present in these tumors. So in summary then, this combination of panabinostat and things results in 100% survival of neuroblastoma THMIC-N mice. The efficacy is due to the induction of an immune response. We believe this is a very safe and exciting new treatment approach for high-risk neuroblastoma and also other childhood cancers. And CBL plus benostat is really having a profound effect on the tumour microenvironment. And this is work that we published this year, not only in neuroblastoma, but our colleagues working in our institute in the brain cancer DIPG, which is a devastating brain cancer, also is seeing quite remarkable results. So there is currently a children's oncology group based trial, that is being that is going to commence shortly, which is CBL0137 as a single agent. It's listed on the site, but it's not actually commenced yet. It's commencing shortly, and it'll be for refractory pediatric malignancies, including neuroblastoma. Okay, so just in the remaining time that I have, really what I want to talk to you now is about discovery of a brand new target for high-risk neuroblastoma that we are particularly excited about. Now, to do that, we have to go back to the MYC-N or N-MYC oncogene. N-MYC is the name used for the protein, MYC-N for the gene. MYC-N, I think everyone knows, it's a master gene regulator. It controls thousands of other genes. It's one of the most important genes for the developing fetus or embryo, because it actually ultimately determines when the cells are growing and dividing, when they grow and divide, and how they differentiate into the various organs of the body. And it's critically important for developing nervous tissue, which is the cell of origin of neuroblastoma. And then abnormal activity, as we know, of N-MYC or MYC-N drives the development of neuroblastoma. And that's really nicely shown here, where you can see, so here are normal cells from anybody's body. You could take some normal cells and then use, label the N-MYC gene with a green fluorescence, and you can see that there are 2 copies of the gene. And that's because you inherit 1 copy from your mother and 1 copy from your father. We all have 2 copies of the MYC-N gene. But of course, what happens quite frequently in MYC-N amplified neuroblastoma is what was 2 copies has now been converted into sometimes many hundreds of copies, shown by all the green that we see in there. So you suddenly have, where you only had 2 copies, you suddenly got hundreds of active copies of N-MYC present. The other definitive evidence comes from this TH-MYC-N transgenic mouse model. And our colleague Bill Weiss at the University of California in San Francisco many years ago developed this model. And that's by taking the human N-MYC or MYC-N gene and putting it in to the mouse genome. So 2 copies of it into the mouse genome. The human gene is found in every cell of that mouse, but it's only active in nerve cells, and that because in front of the gene is put a control element which says to the gene, only become active when you're in nerve cells. So that limits the activity of the gene to nerve cells. Now, these tumors that have 2 copies of this N-MYC, 100% of these mice will get tumors, 100%. Before 7 weeks of age. 100% of the mice will get tumors compared to the mice that don't have the transgene. So that represents an excellent model, not only for testing therapies as we've been doing, but discovering new genes and strategies. So what we've done is a mutagenesis screen. So we've taken the compound N-ethyl N-nitroseurea, ENU. This damages the DNA. It causes random mutations in the sperm cells of male treated mice. The mutations occur at a high rate, randomly around the genome, but there's no bias. We don't know which genes are going to be affected. We don't know which pathway is going to be affected. It's a totally random event. But what you do is to screen the offspring for loss of tumors or a delay. So what you do is you take the male mice, you inject them with ENU, which causes these random mutations in the genes of the sperm cells of the mice, then mate them with female mice, TH-MYC-N mice, and then screen the offspring for tumor development. When you do that, what you have is this graph over here on the right. And all of this red down here represents almost 2,000 offspring that were screened. And the vast majority of those, as you can see by this line across here, got their tumour before 7.5 weeks of age. However, there's a little bit of a tail off here, and in particular, because of the break over here and the axis, this goes up to 12 weeks, and then there's a break and it starts at 45 weeks. There was one mouse that reached 50 weeks of age and didn't actually develop a neuroblastoma tumour. And that mouse is number 1590. Not a very useful name, but that's what it is, 1590. The first thing we wanted to know, could we breed that mouse with other THMICN mice and show that whatever's happened is heritable, it can be inherited. So you take the 1590 mouse, you breed it with another 1590 THMICN mouse, and if it is heritable, what you should see is 50% of the offspring will have no tumour or a delay in tumour formation, and the other 50% without this mutation will develop tumours normally, or should develop tumours normally. And that's almost exactly what we saw. So down the bottom here, we're looking, so this axis here shows time to tumour formation, and down the bottom we can see that half the mice, 51% of the mice, and it's an odd number, so you're never going to get exactly 50%, got tumours in less than 7.5 weeks. However, 22 tumours over here, 20 of them never developed a tumour, and 2 of them developed a tumour very, very late. So, and I sort of won't go into it in detail, but we went through a lot of genomic sequencing and back-crossing onto different strands to eventually isolate what the mutant gene was in these cells. And it turned out to be, as I said, RUNX1T1. And you can see here, looking at this is showing that if mice have this mutation in their gene, then it almost completely abrogates tumour formation in this model, just with this one mutation in this gene compared to the normal gene. And so RUNX1T1, what is it? If you look where the mutation lies, here is just a section of the amino acid sequence coming from the protein of RUNX1T1. And this domain here is called the NHR4 domain. I won't go into it, but it's a highly conserved region. So across the top here is Homo sapiens. This is humans. The humans have this sequence of their amino acids. It's a one-letter code for the amino acid that is there. And this region is highly conserved. It's conserved in mice, mus musculus. It's conserved in chickens. It's conserved in frogs, Xenopus. It's conserved in fish, zebrafish. It's even conserved all the way down to fruit flies, Drosophila, down here, with a few exceptions. And most importantly, the mutation affects this amino acid here. It has a Y. This is a one-letter code for the amino acid, but Y means it's a tyrosine, the tyrosine amino acid. And what's happened in RUNX1T1 is that tyrosine has been converted in the mutant form to a histidine. And that's enough to completely disrupt the function of this domain. It wipes it out completely. And I haven't shown you all the studies we've done to do that, but that's what it does. So what does RUNX1T1 do? Well, it's known to be a master switch, a bit like MICN, except unlike MICN, which directly regulates genes, it sort of does it indirectly by binding with other proteins rather than directly to the DNA. It's never previously been known to or shown to have a role in neuroblastoma. This is the very first time. However, it has been shown to be frequently mutated in a subtype of adult acute myeloid leukemia. So there's a certain subtype of acute myeloid leukemia where the gene is actually mutated in that process, but it's mutated in such a way that it makes it hyperactive. So does the mutation switch off RUNX1T1 or cause it to have some kind of altered activity? To address that question, we imported RUNX1T1 gene knockout mice. Now, these were mice that were developed at the Institute of Child Health in the UK, by Dr. Calabi and his colleagues, and they published this way back in 2001. Fortunately for us, it was the only model, gene knockout model of RUNX1T1. And what they'd done is used genetic technology to delete the RUNX1T1 gene from one of the 2 copies present in the mouse. So it was deletion of 1 copy of the mouse RUNX1T1 gene in every cell. So only half the activity of RUNX1T1 remains. However, mice with loss of 1 copy of RUNX1T1 are completely healthy and fertile. Nothing wrong with them at all. So we crossed these mice with our MIC-N neuroblastoma mice. And so that just meant taking the knockout mice with 1 lost copy, crossing them with our transgenic mice that have these 2 constructs in their cell, and then selective breeding these to produce neuroblastoma MIC-N transgenic mice that have either 1 or 2 copies of RUNX1T1. And then obviously what we wanted to know is what effect that had on neuroblastoma development. And we were really, really pleased to see that when the mice had only 1 functional copy of RUNX1T1, this almost completely mirrored what we'd seen with the mutant form of RUNX1T1, that it almost completely abrogated tumor formation compared to those that have the normal 2 copies. And there's a little bit of drag in this because these mice were on a different background before they were crossed and things. But what this shows is that loss of only 1 functional RUNX1T1 gene is able to prevent neuroblastoma tumor formation. So that's in mice, even though it's been driven by a human gene. What about human neuroblastoma? So what we did there is that we took aggressive MIC-N amplified neuroblastoma cells and genetically engineered them to switch off RUNX1T1 when you add a commonly used antibiotic into the mouse food. So here you've got these cells in a plate with an on-off switch we've put in there that can be turned on when you add a certain antibiotic to their food. These cells were subcutaneously injected into the flank of mice. They were allowed to grow up to have a small tumor in the mouse flank, and then one of 2 things would happen. Either they were left as they were, and the tumors would go on and develop normally, but we were very keen to see what would happen when we switched RUNX1T1 off in these small tumors. And so here you can see the survival of these mice the growth of these mice post treatment. And this is the control. These are the control mice starting out with a very small tumor, which exponentially grows to become very big until the mice have to be culled. And then in the other group, where we fed them the antibiotic to switch off RUNX1T1, it almost completely stopped the growth of neuroblastoma in these mice at all. So that's showing that loss of just reducing the level of RUNX1T1 is enough to almost completely stop the growth of these cells, human neuroblastoma cells. And that suggests that a drug that is able to reduce or inhibit RUNX1T1 would likely be a highly effective anti-neuroblastoma agent. So the path we've gone down is this so-called degrader technology pathway to target RUNX1T1. And this really is a transformative technology because it enables a new class of medicines. And I should say the pharmaceutical companies around the world are spending billions of dollars on trying to develop this technology to take it into the clinic. It goes under various names of PROTACs, agronomics, snipers. They all largely have a similar way of working. But what it does do is provides the ability to target proteins that were previously considered undruggable. So technically, what are they? They're bifunctional compounds. One side binds a protein of interest and the other engages an E3 ubiquitin ligase, which leads to ubiquitination and proteasomal degradation. Now, that's a huge mouthful, and I'm sure nobody understood whatever I said. But graphically, let's have a look at it, because what these protein degraders do, they use the cell's inbuilt waste disposal system, the inbuilt garbage system that is present in every cell in mammals. And it's best explained. So if we take an oncoprotein here, and this can be RUNX1T1, what we need to do is develop this thing in the middle called a protein degrader. One end of it has to have a tag that will bind to your protein, RUNX1T1 here, bind into wherever you develop it. Doesn't have to be the active site, anywhere on the protein. Then have a linker region in this protein degrader. And at the other end, you want a warhead that will engage with a specific E3, an E3 ligase binding there. And I should say that in the cell, there are greater than 600 E3 ligases, ubiquitin ligases. So there's a lot to choose from. And when you do that and develop that, that ligase then, this E3, then starts putting these ubiquitin groups, and they're little amino acid, short amino acid group proteins. It just attaches them to the protein of interest. And so that's RUNX1T1, and that tells the cell this has been labeled now for destruction. And so it gets taken over to what's called this proteasome, which is the cell's shredder, if you like, puts it through, and out the other end, all you get are amino acids. So your targets are destroyed. There's no need to specifically inhibit any enzymatic function. Does it work? Well, at the moment, there are over 15 clinical trials that have been approved or about to approach the clinic for a range of cancers. There actually had been a drug approved way back in the early 2000s, in 2010 or so, lenalidomide, which was one of the biggest grossing drugs around at the time. They didn't know its mechanism of action, but it's since been shown to use a similar technique or technology. So what are the advantages? Well, I won't go through these in detail. I guess the biggest one is it's allowing you to drug target oncoproteins which have been regarded as undruggable. You don't have to have an enzymatic function that you're trying to inhibit. It works at low concentrations. It's potentially going to have fewer side effects. Biomarkers are very easy because you're destroying your target. So it's very quickly to see whether you're on target or not. And it's modular, allows combinations, and the graders are likely to be easier to develop and safer. So, we're embarking on this pathway now, and we've shown that RUNX1T1 can be tagged and degraded. And here's the evidence of that. So we've taken neuroblastoma cells, we've put a tag on the RUNX1T1, and then put this into the neuroblastoma cells, and then treated with this ProTag, or the degrader that will come along. And that can be done at very low concentrations. So these are nanomolar concentrations, and that's a very low concentration, down to 10 nanomolar here is enough to almost completely degrade the RUNX1T1 within the cells. And the next steps are, now we want to take this system and put it into our mice, and preferably put it into the THMIC-N mice, so that we tag RUNX1T1 in the THMIC-N mice, and then treat with the warhead that I talked about, with the degrader here, and then look at tumor formation, so the target is validated, and also safety and efficacy. So I'll end it there. And of course, there are a lot of people really to thank that have been very important to this, not only at Children's Cancer Institute, where I work very closely with Michelle, but we've got Amanex Therapeutics, Mark Burns, who developed Amanex 1501, Giovanni Perini and the University of Bologna, John Silk, the Walter and Eliza Hall Institute, Mike Hoggerty over at Children's Hospital in Philadelphia, Andrei Gudkov, who developed CBL0137, and Frank Musar, who we've been working with at the University of Birmingham with BCT 100. So thank you very much.
Thank you very much, Murray. That was a really informative session with lots of exciting projects. And in fact, it's hard to know which one's better. The RUNX 1T1 sounds like a potential knockout in terms of the way forward for research. Is that your view on it, that it could be bring about a cure for neuroblastoma?
If the degrader technology works, yeah, I think it has that potential. From what we've done up till now, but of course, you know, the final step is getting it into patients and seeing it. But everything that we've done to date says that this gene is critical to tumor formation, and we wouldn't have discovered it if we hadn't used the mutagenesis, because the mutagenesis technique that we used was a forward screen. In other words, we didn't say, well, let's knock out this gene or let's knock out this one. Let the tumor tell us which ones are important to tumor formation. And so you randomly mutate the genome in the sperm cells of the male mice, and then just look at the offspring and just saying, do we have any mice that don't get a tumor? And you have to hold your nerves because you're going through an awful lot of mice. But as I said, you know, by the time we got up to the 1590th mouse, we've got one that didn't get a tumor, and that was quite an exciting time when that happened. So. Yeah,
no, totally. Mouse 1,590 might go down in history. So let's see. I've got a few questions that have come through. CBL0137 and panobinostat, which is obviously another very promising research area. In a real patient, how would you ensure that the immune response is triggered? Will the trial include some kind of stimulator? And when to expect this combination to go into actual trial?
Wow, all very good questions and things. We certainly expect it to induce an immune response, and that immune response would have to involve interferon, as we've shown, because that's the pathway that really has been targeted when you use those two drugs. And there are biomarkers that you could measure to make sure that that is occurring in mice. One of the problems that we're facing at the moment is the company that actually owns panobinostat doesn't really have any great desire to take it forward into the clinic at all. And until we can convince them otherwise, we're now actually, fortunately, the fortunate thing is that panobinostat, as I said, is what's called an HDAC inhibitor, which is a histone deacetylase inhibitor. And there are lots of other histone deacetylase inhibitors out there. Panobinostat just happens to be one of many. And we're currently screening a number of these others, and to see that they're going to still give us the same effect. But watch this space, what can I say? You know, it's you always want it to be faster than it is, and you get so frustrated when there are always hiccups along the way and things to stop you doing what you're doing, but you can just, all you can do is persevere.
That's right. And I think it's useful to know, particularly for parents, that everybody's just trying to drive this as fast as they possibly can, because they know it will make a difference. Yeah. Another question here. Congratulations for your impressive work. Do you have any opinion about DFMO as a maintenance low dose option and its theoretical action in targeting cancer stem cells, especially for NMIC amplified?
So I think that's probably referring to some work that's been done in the state from Giselle Scholler's group, I think, who's done that, and their trials going on and using low-dose DFMO. Look, there's some of the results coming out look like they're having an effect. At one level, I'm kind of surprised, because I did show that dosing level with DFMO, and really to see an effect, you have to use quite high levels, because in the neuroblastoma cells, which are NMIC amplified, they've got very high levels of MYC, and the very high levels of MYC are driving very high levels of the polyamine pathway, not just ODC1, but the whole pathway is being upregulated. And so using low levels of DFMO, I'm just not sure you're going to be knocking out enough of the ODC1 to see really hugely significant effects. But if the effects are there, that's fantastic, being able to use low doses. But from the work that we've done, and particularly using it up front, not using it in a maintenance or very low level of neuroblastoma, you can see that when you've got an NMIC amplified sample driving aggressive neuroblastoma, DFMO at a low level won't do much to it.
So going back to RUNX1T1 deletion, in theory, it would act as a single agent, if that's correct from what you've said. If the mice experiments show such a level of promise, when do you expect this to get into clinical trial?
It's the age-old question. As I said, it's not, until this protein degrader technology has come along, well, everybody knows if you could knock down NMYC in the cell and the NMYC amplified cells really degrade it, that would be a great treatment in its own right. And there are groups out there, pharmaceutical companies, that are looking at MYC, which is the partner, which is also one of the family of the MYC family of oncogenes, looking at doing precisely that. But up until these protein degraders came along, they've been considered undruggable because they're not enzymes. They don't have an active pocket that you can develop a drug to that will bind to and inhibit that enzyme activity. But this technology, as I said, pharmaceutical companies are spending billions of dollars on. They regard it as the next big thing. Whether it turns out to be that, of course, remains to be seen. RUNX1T1, if we didn't have protein degrader technology, would be classed as probably undruggable as well, because it doesn't, again, it's not an enzyme, and it's not something that sits in the membrane of the cell and things. But fortunately, we've got our collaborators in Melbourne at the Walter Eliza Hall Institute that are setting up a centre for this technology, and they see this as one that is really, really promising, and they want to sort of put it up near the front of the queue and things like that. So, when would it get into clinical trial? It's got to wait. Once the technology has been proven by some of these other clinical trials companies that are going on, then I think you might start seeing some fast tracking going on, because if it's a proven technology, shown to be safe, shown to be effective, shown to be able to work at very low doses of putting in this warhead and things, then that could be a big game changer for not just neuroblastoma, but for any tumor that you want to look at, where the driver of that particular tumor and things. So I don't want to hype it up, because there've been too many cases in the past where that's happened, and it's failed to show the promise that's been hailed for it. Except that I will say that I mentioned this drug lenalidomide, which is used to treat multiple myeloma patients. It's one of the world's biggest selling drugs. And in 2014, they didn't really know how it worked. It worked and worked very well. But in 2014, they actually published showing that it works by a very similar method of using this E3 ligase to actually degrade the protein of interest. So at least there's evidence that already out there that there's a drug that works along that pathway and is highly effective and things.
So we'll wait to see, hopefully, the development of the degrader technology, and then we will hopefully see the impact on neuroblastoma tumours. I've got a question, really the last question. Have you tested these combinations in other or different mice models?
Yeah, we have. So we've David Ziegler, I think, was on earlier today. David Ziegler's also in our institute and a clinician, and he's very interested in DIP, diffuse intrinsic pontine glioma, and that's a tumour which is 100% fatal. There is no treatment for that tumour, and he's been looking at the combination of DFMO and Aminex 1501, and published a paper this year that I was a co-author on, that showed that it was highly effective also in DIPG. We've got our own data in sarcoma, which is another tumour type that needs some new therapies for. It looks like it's might be really effective there. CBL0137, on the other hand, is showing that it's potent against a range of different pediatric cancers, not only solid tumours like neuroblastoma and DIPG, but also leukemia as well, acute lymphoblastic leukemia. And so, yes, a number of those drugs, and BCT100 in the clinical trial is taking all comers, solid tumours and liquid tumours as well. So we have to wait and see what the outcome of that is. But the potential is certainly there.
Thank you. Thank you very much, Murray. And thank you so much for your time and going through in so much comprehensive detail for everybody. It's really exciting to see all the work that you're doing. And I know it's a bit of a lifelong mission for you, this area. And we're very honoured to the fact that you're still focused on trying to get better results for all the patients with neuroblastoma, and wish you lots of success in your continued research.
Thank you very much, Lucy. It's a pleasure. Thank you.
Thank you. So we've now reached the end of this session, and if you're viewing from the Neuroblastoma Parent Global Symposium, there'll now be a break in the programme until 4 p.m. Greenwich Mean Time, when we'll return with Dr. Daniel Morgenstern's welcome before the Coping with Diagnosis session commences. If you're watching from Neuroblastoma Australia's Family Conference, this completes our sessions for today, and they will start tomorrow at 7:45 a.m. with another live-streamed joint session. You can, of course, join the Neuroblastoma Global Symposium and continue watching from there too. Thank you very much for everybody's enthusiasm and attention for today.